Good evening from Colombo, Sri Lanka. I am Dr. Ratnasiri, the president of the SSCOG. So I welcome you to the 11th in the series of live webinars organized by the Sri Lanka College of Obstetricians in collaboration with the RCOG Liaison Group Sri Lanka. I hope you all are enjoying this webinar series. You can see with the numbers joining the webinar. So today we have Dr. Luxmi Velauthar. She's a fetal medicine specialist. So she's going to talk to us today for 1 hour more on recent advances in fetal medicine. So we have Dr. Rajkumar at the other end. So I'll invite Rajkumar to introduce her for the webinar. Thank you, Raj.
Thank you, Dr. Ratnasiri. So welcome all of you. Good evening for those in Sri Lanka and good afternoon those in UK. So as Dr. Ratnasiri mentioned, this is our 11th webinar and I hear that this is going very well and the Sri Lankan postgraduate trainees are benefiting out of it. So today our topic is recent advances in fetal medicine and the speaker is Dr. Luxmi Velauthar. Dr. Velauthar is a consultant, obstetrician and gynecologist at Bart's NHS Trust. She qualified at University of Dundee and undertook a specialty training in London. And she is the lead for both obstetric and fetal medicine unit at Newham General Hospital in London. She gained her MD at the University of Queen Mary and presented research work both at national and international conferences. She has a particular interest in fetal medicine, pregnancy complications, and with extensive experience in preterm pregnancies and preeclampsia. She has a passion for teaching and she teaches and examines for undergraduates and postgraduate medical degrees. She's a course director for obstetric ultrasound course, practical gynecology laparoscopic training, and for the RCOG robust course at Newham General Hospital. In addition, she currently leading charitable projects locally and internationally to improve women's health through teaching and training both staff and patients. And you remember once we came to Sri Lanka, we did two multidisciplinary course on obstetric emergencies. So some of you may have met Lakshmi. So over to you, Lakshmi, for your talk on recent advances in fetal medicine. I would like people to participate. So if you can send your questions so we can discuss towards the end of this presentation. Thank you. Over to you, Lakshmi.
Oh, thank you so much for inviting. I really thank Dr. Rajkumar, and I'm very grateful to be part of this SLOG and RCOG initiative. I think it's a great thing, especially during this COVID time. I think it had brought everyone together. And to be, I think I can see already about 71 participants on a Sunday. I think that itself shows how well the webinars are going. Anyway, I hope you enjoy. So I'm going to start off with the topic that I've been given is advances in fetal medicine. Now, the fundamental question any woman wants to know is whether her baby and herself are going to be all right, because that is every woman's dream is to make sure the pregnancy goes well very smoothly. There has been major advances in particular with fetal medicine, and that can be because of lots of research around the topic, or it could be because there is advancement in technology. I'm just trying to change. Sorry, just give me 2 seconds. Oh, there we go. It was working fine. Okay, perfect. And I'm going to start off with screening for Down syndrome. We do screen for Down syndrome, not only in this country, but in many countries. So to make the screening more interesting, I thought I should start off a little bit on about the history of how Down syndrome screening evolved. It was first reported by John Langdon Down, who first described the Down syndrome as Mongolic child of European parentage. That was in 1862. Remember, the word Mongolic is something that you cannot use now. People do get offended, so it's no longer used, but that is how it's been described in 1862. So the incidence of Down syndrome is about 1 in 800 to 1,000 births, and it is one of the most recognizable form of mental disability. They have many features, but not all of them that you can identify on the ultrasound. So this is why we need a screening method. So in just 2 seconds, my computer is taking a little bit long. I don't know what happened. So in 1960s, it was the Catholic pro-life pediatrician and the geneticist, Jeremy Lejeune, who first identified the extra chromosome 21. And about 7 years later, the abortion was legalized in England. But I understand that it is still illegal in Sri Lanka to terminate. And this was from the Penal Code of 1883. And anyone involved, I was told that with termination of pregnancy, can risk imprisonment up to 3 years. But I know there are lots of talks around trying to legalize in Sri Lanka, but so far, no luck. I'm so sorry. Okay, it's just taking a little bit to load. It was working very well earlier, so I'm not sure what's happening. Anyway, so now in 1970s, again, what they found is that 1/3 of the women, about 30% of the fetus with trisomy 21, is in women more than 35 years of age. And the detection rate, just based on the age, is around 30. It's roughly around 30%. So it's not so good. But what happened in 1980s? This is when the core test was introduced. This is still currently available, and this is for those women who have missed their combined tests. It is a second trimester biochemical testing, looking at the beta-HCG, alpha-fetoprotein, estriol, and inhibin. And the detection rate is roughly about 71%. So it is definitely better than the age alone. But for women, in order for them to terminate, it is better for them to know the outcome sooner rather than later. So what happened in 1992? So this is when the huge changes started to happen. Introduction of nuchal translucency. This is to measure the fluid behind the baby's neck. So Professor Nicolaides is still professor at King's College. So what he found was that increase in nuchal translucency not only increases the risk for Down syndrome, but it also increases the risk of other aneuploidies, including, it can, the other aneuploidies can be as high as 35%. So in 1990s, the detection rate just based on the size of the baby, the measurement of nuchal translucency, the detection rate improved to 80%. So that's still not good because you're still doing more invasive tests. So what happens next? Along the same era, there was an introduction of free beta-HCG and PAPE, and these are the placental protein that are measured as part of the combined tests. And so what they found was that the detection rate was roughly about 65%, just based on this beta-HCG and PAPE. So what do you think happened next? So what you need to understand is that when there is increased nuchal translucency, it does not just mean Down syndrome. It has got other implications, such as it can increases the risk of cardiac defect, especially the babies with Down syndrome can have a cardiac defect as well, but it can also increase the risk for other aneuploidies and genetic problems. So increased nuchal translucency is not just for Down syndrome. So in 2000, what happened? They decided that they will bring everything together: the maternal age, the size of the baby, the nuchal translucency, and then the serum beta-HCG and PAPE. So they combined all of this, and this is what is currently being done, and it is called a combined test. And the detection rate just based on this is around 90% for a false positive rate of 5%. And this is still involves quite a lot of invasive testing. So the mothers were not happy to go through that for reasons that you can all understand, because they want to reduce the risk of miscarriage. So did the test get even better? So in between 2000 to 2010, there were other markers. So we started looking at other markers such as nasal bone, tricuspid regurgitation, and also ductus venosus. And the detection rate improved to 97%. But in many centers, these additional markers are not used. And it was not made compulsory because of many reasons, because of cost issues, training issues, and so on. So what happened in the last 10 to 15 years is there has been a great progress, especially with the introduction of free fetal DNA and the ability for us to isolate from the maternal blood. So how well are we doing it? It was first reported by Lowe in 1997. It originates from a trophoblast seen from 5 weeks onwards. So what we did not expect is that about 10 to 20% of the DNA in the maternal circulations are from fetal cell-free DNA. And the concentration of this increases as a gestation progresses, and it is cleared within 30 minutes of delivery. And there are several studies showing that the sensitivity for the Down syndrome is between 98 to 100%, with a specificity of 99 to 100%. So the detection rate is not only high for Down syndrome with a false positive rate of 0.9%, but it is also pretty good for Edwards syndrome, that is trisomy 18, and trisomy 13, which is the Pateau syndrome. But obviously, these are still issues. There are lots of issues with cell-free fetal DNA. especially if it is twin pregnancy, or is a failed results because it's an early gestation, or the woman has got high BMI, or whether if there was any impaired placentation, mosaicism, and if there's any genetic problem. So it can still be a problem. So this is just to show it, you know, how free fetal DNA has become far superior in terms of screening for Down syndrome, as well as Edwards syndrome. So the detection rate, as I said to you earlier, is more than 99%. And then, you know, you can see, you can ask a question, why do we bother doing the combined test anymore? So it's, but do you remember what I said earlier, that it identifies increased nuchal translucency, and it is not just for Downs, it can detect other structural problem and genetic problem and the other aneuploidies, and especially PAPE in particular. What you need to know is low PAPE is associated with preeclampsia, growth restriction, and also stillbirth. So when a woman presents with low PAPE, we do screen them to identify whether they are at risk of developing these conditions. So combined test at 12 weeks. I thought, yeah, so these are, you can see how well when you combine all of them, you can improve your screening. I'm not sure whether you want to ask questions now, because I'm now going to move on to the next topic.
There aren't any questions, Lakshmi, but I thought of asking why bother doing the combined, but you already answered it. So is a cost comes there, the NIPT?
Yes, definitely. So there is a lot of, obviously they are very expensive, free fetal DNA. Still, even in UK, not all the hospitals offer that, but we at Barts Health, we offer them. But this is only for those women on the combined test if it is found to be high risk. So if it is more than 1 in 250, then they are offered this test. And it is expensive. It is, at the moment, it is charged £300 per test. So it is quite a lot of money. So for those women who wants to have it done, they can have it done privately, but with an NHS, you know, only offered for those women found to be high risk.
For the benefit of people who are sitting for MRCOG, so before you see this patient, what kind of counseling that you should take or you do before you do a test? What kind of counseling you have to do, implications of a positive test, and so on and so forth?
Yes, so it's still classed as a screening test, purely because there is still that, you know, it is not 100%. So all these women, when they are being counseled for the combined test, and they are being told that if the risk is higher, then they will obviously will be offered, or they will be, you know, offered to have this free fetal DNA. So they've been told well in time. And for those women who do not want to have Down syndrome screening, then they have got the option not to have these things done. But what we tend to say is that all these screening, like especially not for the free fetal DNA, the combined test in particular, it is important to counsel them appropriately, because even within our hospital, the women who opt to have a screening test is not as good as we would expect. And it's purely because what they think is it's all about Down syndrome screening. It is not about Down syndrome screening. So let's say if a woman comes in, like, you know, when they come in, the combined test, the increased nuchal translucency is not only for Down syndrome and other chromosomal abnormality, it also increases the risk of cardiac defect. So when there is a when there is a low PAPE, which is part of the combined test, it increases the risk of preeclampsia. It increases the risk of growth restriction as well as stillbirth. So if you tell these women that, it is not just for Down syndrome, it is also for other fetal abnormalities and the women at risk, and these women tend to go for it. It's all about how you counsel these women. Although the detection rate is not as good as Down syndrome, it is still there. So PAPE of 0.4 mom or less increases the risk of IUGR, stillbirth, as well as preeclampsia. So once you identify them, you can start them on aspirin as early as 12 weeks and so on. So which I'm going to cover on the next topic.